Welcome, everybody. Thanks for sharing your evening tonight with all of us. I think tonight's about the future, and the future's really now. I think this course is going to make you think. I get to co-present with Dr. Stephen Moore, far more on the genetic side. I'm obviously on the dental side. And after 40 years in practice, and there's so many question marks that I keep coming up with throughout my career, I really want to kind of address some of those as we rethink dental diagnostics. So when you look at traditional diagnostics and the approach that we've had really for the last 70 plus years, it's been x-rays, explorers, and perioprobes. And that's diagnostics. And I'm going to come up with a term. And my term is reactive. And I think the way we currently diagnose caries is mainly related to a reactive approach. And the truth is, it's the same with perio. You look at x-rays, you probe, and then we treat. And it's really a reactive approach. And this is what we've been doing for 70 plus years. And yet, what we've been told isn't necessarily true. And what I mean is if you have a patient who has no bleeding on probing, then it is 98% indicative of future good periodontal health. Yet, if someone has bleeding on probing, and obviously the number of pockets would vary, it is only based on the literature predictive 30% of the time of future attachment loss. So it's not very predictive. And that's a key point for tonight's course. So how important would it be to finally have diagnostics in our grasp that are predictive of future oral disease? Imagine knowing that you're going to have bone loss way before you have bone loss. Or imagine if you have a high-risk caries patient who has a small enamel lesion in E1 or in E2, and they're high caries risk. And we'll talk about what makes them high caries risk and how these lesions can spread to D1 and D2 in more high caries risk patients. Yes, of course, we're going to talk about diet and flossing and everything else. But I'm here to really have you rethink diagnostics. So if you could easily implement a one-time only, once in a lifetime only predictive test for caries and periodontal disease, would this be valuable to you and your patients? In other words, knowing if they are genetically susceptible to caries and periodontal disease. And it's not exclusive. It could be one or the other or both. If during recall appointments, you were enabling saliva testing, totally different than just pure genetic testing, could that be more indicative of risk factors while you're treating patients? Would you start adding such diagnostics to your practice? And saliva testing, like genetic testing, is really in an infancy in the dental profession today. So if you knew your patient was genetically at high risk for periodontal disease or high risk for caries, how advantageous would that be for you and your care and prevention approaches? Likewise, what if they weren't? And these are very distinguishable ways that you would be approaching a patient. So I'll start with the true or false. Genetics has a substantial role in caries risk factors. True or false? And if you're saying true, the answer is true. But yet, here we've working years and years in our careers. We're not looking at genetics on a new patient exam or a recall exam where a patient is failing. And yet genetics is tied incredibly closely with caries risk factors, which we'll get into. So this is what we've all learned in dental school. So the idea of caries is you got to have a host tooth. Then you add a substrate, obviously what you're eating, carbos routinely, sugar. You have some strep mutans or lactobacilli, and over time, you get demineralization. That's the model. And based on that model, that was then, if they were getting a lot of cavities, we would then look at strictly diet, microorganisms, and home care. Well, there's another big piece to this, and it's called genes. And the genetic component of high-risk caries or low risk really deals with everything you just saw come up. Whether there are saliva factors, which I'll show you, your immunity, altered taste, surface dentition, and the microorganisms. These are all affected by genetics. And so it is my belief that over the next number of years, genetics, like a blood test in a medical office, is going to become almost part of our foundation for predicting patients' risk factors, and then saliva testing for recall appointments to see how are our patients progressing. And there are a ton of saliva tests out there. Genetics has a substantial role in periodontal risk factors, true or false? And the answer is very true. At least 50% of periodontitis susceptibility is credited to hereditary or genetic factors. And I'm going to get into this before Stephen gets on tonight. So, like, Lou, what's the research? And the research is overwhelming. We're almost entering 100 years of research, countless studies that demonstrate a genetic involvement with patients at risk for caries. And when you look at the studies, decade after decade, from the 30s, 40s, 50s, all the way up till today, it all shows genetics and their relationship with caries. We'll get to perio next. So there's a classic study called the Vippeholm study. And the Vippeholm study, now 50 plus years old, was conducted on 430-ish subjects. And what they did was the goal was to have a control group and a treatment group with the aim to determine the relationship between diet, frequency of sugar intake, and dental caries. Now, I don't know whether you learned this in dental school. I did not. And if I did, I totally forgot it. Sugar was administered in a solution during meals, or patients were given bread and toffee in between meals. And the study showed positively that sticky sweets, which is what we would all believe, consumed between meals rather than during meals, had a significantly higher incident rates of dental caries. And it showed the major involvement of carbos in the development of carious tooth lesions or carious tooth surfaces. Fine, we all know that. Great. Yet, there were two things that the study really ignored. One is, despite sugar consumption in various subjects, they did not develop new carious lesions. So they had either snacking or high sugar consumption, and they did not develop caries. We would call those patients low risk. Other patients were not consuming high amounts of sugar, and yet they developed caries. So they were high-risk patients. So these were two anomalies that were really ignored in the study, and that's why we're here tonight. So genetics really can affect the caries up to 65% of how someone is susceptible. So let me just show you how genetics plays a role in caries. The first one is crowding of teeth. You know this is genetic. So crowded teeth are more prone and have more challenges with home care. This is why aligner therapy has turned into a home run with all of us, because we're trying to make it much easier for patients to obviously brush and floss their teeth. Enamel. Enamel plays a very strong role in determining, obviously the resistance to, demineralization. Genes play a strong role in determining the composition of tooth enamel. And we've seen that where patients have white spot lesions naturally, or they have enamel that's more prone to caries. That's genetic. Genetics can have a huge effect on the amount of saliva a person produces, as well as whether it's a thick, ropey or a clear, the flow rate, the pH, and the buffering capacity. So I think this is a key point. Most people don't realize this is genetically driven. And then what we can be doing is doing saliva tests on our patients to find out, do they have a buffering problem? Do they have a flow rate problem, a pH problem? But those are genetically driven. And then additional tests will allow us to truly understand what those issues are regarding the saliva. Genetics also affects how the body responds to the caries process, the infectious process in itself. So these are the multiple ways this occurs. And lastly, genetics can also affect your taste. And when your taste is affected, then your dietary perception changes. And then as a result, you could be eating, we'll say, higher caries risk foods. So taste, again, genetically affected. Now let's talk perio. I'm going to tell you, you thought caries was complicated. Perio's unbelievable. And I will just to say this, all immune responses are not created equal. So here's my favorite slide. You look at number one, that's the microbial community in your biofilm. And now that is what's obviously in our pockets. And then you look at number two, and that's our host immune response. And the zone of interaction is that small area in between. And look how complicated this is now. So as number one, as you look at the local environment, and now how does your oral hygiene, saliva, diet, all of these things come into play. Then you add the population, the age of the patient, the gender, the genetic code. Now you add environmental factors such as smoking. Then you add systemic diseases like diabetes, obesity, and others. And all of this comes into play in periodontal disease, not just 2, 3, 5 bleeding point. And what do we then have to assess it? We can take cultures, we can use microscopes, DNA probes, and other things to assess the disease activity. This is the complexity. The research, again, dates back decades and decades. And there is an absolute causal relationship, not casual, but causal relationship with genetics and periodontal disease. So this is what I got trained on. This is the Kornman study. So you have your typical microbial challenge in your pockets. And the host is really, how does it respond with antibodies and PMNs, obviously, to the microbial challenge? Well, what affects the host are environmental risk factors and genetic risk factors. These two modify the host response. And if they modify the host response in a negative way, cytokines, prostanoids, and MMPs are then released, and they create connective tissue and bone metabolism and basically bone destruction. And then you obviously see all the clinical signs. Again, look at how environmental and acquired risk factors and genetic risk factors fall right into play on the host immune response. Now, that was in 1997. Offenbacher studies really were pivotal studies. And what Offenbacher noted was this multi-level predisposition to really understanding the disease model. So here's key factors. If you're a smoker, we all know this, you're 5 times more susceptible to periodontal disease. And this has nothing yet to do with genetics. A diabetic, 2.8 times more. Obesity, more susceptible. So when you look at comorbidities, this becomes huge. How huge? I'm glad you asked. Diabetes. There are close to 40 million people in the United States who have diabetes. 40 million people. So realize their risk factor for periodontal disease. Let's talk pre-diabetes. Now let's add almost another 100 million people, 38% of the population. And these are people all walking into all your offices. 2 huge risk factors. Now you add obesity. You know this is a huge problem. 100 million adults in the United States, okay? And then 22 million severe obesity, huge risk factor. Smoking. So 11.5% are still smokers with cigs. You've got basically about 17.7 million now of smokers smoking marijuana, and I think that's probably a low estimate. So we're looking at smoking as cigarettes, marijuana, e-cigarettes, cigars, smokeless tobacco, pipes, vaping. All of these things, higher risk factors. Now you get into the genetic and epigenetic composition. This is what this course is really all about. So we know we've got comorbidities, but when you look at least 50% of periodontitis susceptibility is credited to heredity or genetic risk factors. So if you've got a diabetic who's genetically prone, think about the risk factors and what you're going to do for these patients. So there are a couple terms I got to throw at you, and I'm going to read it. Epigenetics is the ability to alter gene sequence. So it's been established that aging, microbial exposure, dietary factors, systemic conditions like obesity, diabetes, osteoporosis, and depression, environmental factors like pollution, as well as modifiable risk and lifestyle factors such as smoking, stress is a big one, and alcohol consumption, have the capacity to create epigenetic changes, which means they can change the gene sequence. So when Stephen talks about gene sequencing, these are all the factors called epigenetics that actually can change the genes. And those sequences can have dire results. That's epigenetic and genetic. What Offenbacher dived a little bit more into, which you will relate to, are the biologic phenotype, which deals with cellular and molecular response, along with inflammatory biomarkers. Now, a biological phenotype in periodontal disease refers to, obviously, the characteristics of the tissue and bone. And they together represent the overall, I'll call it the look of the periodontium. And it can be used to assess the severity of periodontal disease. Essentially, the way I try to make this simple, it's the physical manifestation of a person's genetic predisposition to periodontal disease that is influenced by environmental factors like plaque buildup. And the last is the clinical phenotype of the patient. And this really refers to in regards to periodontal disease, the observable characteristics or traits of an individual's periodontal health that are directly influenced by their genetic makeup, including gum inflammation, bone loss, and susceptibility to developing periodontal disease. All of these things are components of periodontal disease. This is what we don't think about in our practice every day. So with that as kind of a guide, I want Stephen now to take over. unmute himself so he can kind of explain really genetic profiling. Stephen?
All right. Thank you, Dr. Graham. So thank you, everybody, for joining this evening. My name is Stephen Moore. I'm a medical geneticist by training, and I'm with AI Genetics. So over the next, 10 minutes or so, I'll walk through what oral risk is all about and focus on how this can unlock your dental code. So next slide. So the kit itself is very simple that you would have in your clinic. So you see an example here where it has the box, and inside the contents include brochure, some information, and importantly, a cheek swab shown at the bottom in the packaging here. So it's relatively straightforward. It takes a very small amount of time to take the sample. And what we'd be doing is just collecting tissue that's cheek cells that are already in the mouth, and we'd be collecting those and sending them back to the lab. So I'll walk through a little bit beyond what goes beyond this kit, but this is what you would receive in the clinic.
How it works. After purchase, go online to create your profile. Follow instructions and mail the kit back. We analyze your genetic profile and provide insights, helping you and your healthcare provider build a personalized health plan.
All right, thank you. So what we're doing with this test is we're assessing individuals' risk of developing two of the most common conditions. And I'll get to why we selected these in a bit. And these not only affect your oral health, which we talked about, but can lead to more serious health problems. So these two conditions are dental caries and periodontal disease. What'll happen is that at the finish of the results, you'll get the test that plots out an individual's relative risk and where they're going to fit compared to the general population of developing a periodontal disease or dental caries. And so what you see is that this one test result, and I'll go through the report in more detail later, is this follows you for the rest of your life. It's what you inherit when you're born. And so you just have to get this test once, and it'll put you into different categories, one of three for each component. So it'll be either for when we look at periodontal disease, you'll follow into either a low risk, an intermediate risk, or a high risk. And that's the same if we look at cavities, you can fall into either a low risk, intermediate risk, or high risk. So we put this user interface for people so it's very simple to look at where you fit compared to the relative population. So what you heard from Dr. Graham is there's a huge genetic component. There's overwhelming research, as he said, around the genetic impact and factors that go into creating these two dental problems. And that is actually what led us to produce the product for this market. We looked at a lot of different diseases in different states and different areas, and we had to find some areas that had a very, very strong component that allowed us to develop our tests. And so it's not a coincidence that Dr. Graham was talking about all the data and the research, because that's the research we read and studied. And we really focused in on what are called genome-wide association studies. And these are studies that can potentially have tens of thousands of people involved. And they try to identify specific changes in DNA that is common to all these people that have problems. And that's what led us to developing this kit and this solution. So after we've discovered that there is an emphasis of the genetic markers and they have a very strong correlation to the condition, which we heard about previously, we select the product and we select these markers. And each single marker is ranked and weighted based on all the literature on that specific marker. And so we have a curation of a panel that includes markers with the greatest impact in condition or the disease. And we can weight every single marker associated with all the different research. And because of that, we can have a very confident score on the risk factor relative to the population. So for example, there's some tests out there that may look at one or two markers. We're looking at 25 markers for periodontal disease and 35 markers for dental caries. Nobody else in the market comes close to this. We're specifically honed in to find something that has an overwhelming evidence in the literature. We found it with periodontal disease, and dental caries, and that allows us to create this very targeted panel. This isn't new research. This is actually what's already been trying to use in the clinic for oncology, for example. Shown here on the right, there's a polygenetic risk score for prostate cancer. So they're developing this for cancer therapies. And so we're taking the same methodology and we're developing it for your dental clinic. So this is what's called a polygenetic risk score. And like I said, we're correlating a list of markers or variants against the standard population to assess an individual's risk. So really what happens? So once that package goes in the mail, you saw it, it's received at the lab. So we have a team of experts who are certified geneticists and lab trained. They're technicians at the Genome Center at Mount Sinai Hospital in Toronto. So what happens is the DNA is extracted from that cheek sample in the lab processing. We then amplify the material for analysis, and then we analyze and validate the samples with various different markers. And once validated, we can then begin to get the data from it. Once that data is received, it's interpreted by certified geneticists to make sure that there is a correlation with the marker and the test, as you see on the right, that's what they do. And then we get a raw data, and that raw data is put into our algorithm for a polygenetic risk scoring. And after that's completed, the final output is the report that's generated that would be available for the user or the patient. So this kind of walks you through, I have 2 pages here. The first page is kind of high level, visually easy to look at. And you see here quite easily that this patient has a periodontal disease and they have a high risk of periodontal disease. So they're falling into the outliers on the far right compared to other people in the population. And then for the person, just a quick kind of explanation to explain what this means. For example, out of 100 people, their risk is higher than 2/3 of the other people. And similar for cavities here, this person has a low risk for cavities. And it's explained easily for people to understand and showing, for example, out of every 100 patients, your risk is lower than 2/3 of the other group. So in addition to this, we build out a couple bit more details for those people interested. So we can provide a detailed summary of what periodontal disease is, what dental cavities are, and how this kind of relates into it. And then we walk through a very simple bullet points of 4 bullet points around explaining the results. We provide next steps, so advising them to discuss these results with their dental healthcare provider and help them tailor their plan so that they can assess their health scenario and their genetics into their oral hygiene care plan. And lastly, we put a page of details that not everybody wants to look at, but if you were to give this to somebody who's trained to look at it, it's set up so that you can very clearly see what has gone into the study. We give all the references if people want to go into a deep dive of the research. We talk about the limitations of the test because as all tests, there's limitations. So this is a full disclosure of what goes into the test and the limitations and methodology as well.
Can you hear me?
Yeah.
So let me ask you this, and I hate to interrupt, but this is fascinating, and some of this is new to me still. So when I look at description of P-risk categories and it says high risk, are we talking that patient's in the 95th percentile of risk when they're high risk?
Yeah, so that would mean out of 100 patients in the population, then 95, they're in the top 5% of risk for developing that.
People can pass it over now to Suzanne to talk about the portal. Suzanne, are you on?
I am. Thank you very much, Dr. Graham. My name is Suzanne Carreri. I am VP Wellness, and I support overall operations. I'm just going to talk briefly about the portal. In the video that was shown with Dr. Moore, they discussed the patient profile. So this is a brief overview of what that is and what it's for. So this is the patient, the portal itself. And as you can see, there are 2 ways that you can register. There's the clinic registration and patient registration. Patient registration is where you sign up a person individually. However, I believe most of you would be interested in the clinic registration, where you set up your clinic first, and then every time you sign up a patient, they go underneath your clinic so that you have one place to be able to look and see all of your patients and the results. So when you go to sign up a patient, you'll be asked to fill in some basic information about the patient and their email address, so that an email is then generated and sent to that patient so that they will have access to also see their results. A very important part of this is the barcode. So every single swab, as Stephen showed you in his presentation, every single swab has a unique UPC barcode. And that barcode is then entered for that patient, for the swab that was used, to uniquely identify them without having to use a name or any other personal information, so that the process can be completely blinded and anonymous. Now, as a clinic, you can log in, and within your specific profile, this is your dashboard, and you can see here your patient results. You can look up any specific patients, you can add a new patient, and also take a look at other reports that are available. So this is your overall dashboard and how you'll interact with the system. We are going to be doing every Monday night at 8:30 until the end of the year. I will be holding webinars or I guess information sessions online through Calendly, and that will be sent out to you post webinar with a link so that you can go in and register. We'll be going through the portal in more detail, how to read the reports in more detail, and general Q&As.
Suzanne.
Thank you.
So I thought then what we would do is kind of look at two patients in my practice. This is Elliot, 28 years old. Medical history was non-contributory. His uncle was his dentist since childhood. He's had 10 plus restorations in the past 10 years. So we would call him a high caries risk patient. In his dental questionnaire, this is what we would ask. He says occasional snacker at home when working. He works part-time at home and part-time at the office. Definitely says not a soda drinker, brushes twice a day, power brushing, and does not floss. He hasn't been to a dentist in 18 months. So these were his x-rays, and we'll take a little bit of a closer look. And you can see at 28, he's already had multiple restorations showing high caries risk, and you can see some new lesions. In this 2D imaging with Pearl, and that's what we have at our office, I'm going to try to show you, and this is via what we call tooth parts, where we talk to our patients. And so it's kind of color animations of teeth. But I want to show you two specific things. These small areas that are a little brighter in pink are incipient lesions. So we'll call them E1 or E2 lesions. And then he also has lesions that are D1 lesions that are already progressively indenting, 40% here. So this is using now Pearl just as an explanation opportunity to talk to Elliot. This is his charting. He had multiple fissure areas of decay and interproximal areas, so multiple class 1s and class 2s. And so the question is, would you not want to genetically test a high caries risk patient to establish a baseline of risk? And I'm going to ask you all this. When you tell patients to floss and brush, is that enough for everyone? And I'm going to clearly tell you the answer is no. And we all know that. So I tried to break this down. What if Elliot came back genetically low risk? So his test came back low. Let's say it came back low. So then we'd have to look at his diet, because for sure we'd have to be discussing that and monitoring it. We'd be establishing better oral hygiene, because obviously what's failing? Obviously brushing. Is he brushing in the correct manner? How much time is he using? And then we talk about flossing. And on your right is a new product that we've evaluated at Catapult, and it's called Slate. I have one I've given it to all my kids for the holidays. My entire family has it. It's a power flosser. It is so much better to me than traditional floss. So now, would I be upping his game and now recommending, for example, Slate? Biannual Profies, are they enough with varnish? Varnish is indicated only for high caries risk patients that have demineralization, not for everybody. So of course we're going to be varnishing them, but is twice a year enough? You could add fluoride mouth rinses. That could be recommended. You could put them on a higher fluoride releasing toothpaste. You could put them on remineralization pastes. And the studies show if you use a paste and floss afterwards, you can try to remineralize proximal areas. And then the question is, if you know he's not high caries risk and he does all of the above, would you just watch the E1 and E2 lesions, or would you do something, which I'll get to next? And would you be inclined to do further salivary testing to evaluate his saliva or bacteria? In other words, are there issues in his saliva, even though he's low risk, or bacterial levels, even though he's low risk? Again, just making you think. Now, let's say he comes back and he's high risk. Would you even be more insistent on recommending varnish treatments, flossing, fluoride rinses, higher doses of fluoride toothpaste? If you know he's genetically at high risk, are you going to take a different tone? And would you do more? So here he's coming in with these E1 and E2 lesions, and you know he's high risk. So maybe flossing isn't going to be enough, or high fluoride rinses or high doses of fluoride toothpaste isn't going to be enough. Well, we have treatments like Icon, Curaden, silver diamine fluoride, Crystal Care. These are all ways to treat interproximal early lesions. Would you increase this frequency to 3 or 4 month recalls? Would you be using different kinds of diagnostics to evaluate changes much more apparent than just X-rays, aka transillumination or NIRI, fluorescence? And all of these are additional to 2D imaging. Would you be more inclined to evaluate and do more salivary testing to evaluate risk factors? So again, we're going to have to go much deeper into prevention. And that could be Slate as the power flosser. What kind of best probiotics would be utilized for targeting caries bacteria? What about remineralization trays? Or a toothpaste that I swear by, it's called Live Fresh. It reduces plaque 250% more than the leading toothpaste out there. Why? It's a total different formulation of an EDTA. And then do you think the patient would be more compliant understanding their risk profile? And I say that because I really believe if patients know they're high risk genetically, I really think they will become more compliant. Or take a new patient like Rena. She's 47. She's had a long history of restorative implant and perio treatments for 20 years. So she started in her mid to late 20s. She's been a type 2 diabetic since she's in her early 30s. She's constantly struggling to control her A1C. She has high blood pressure and treated for it. She's a power brusher. She's a water flosser. She flosses twice a day and wears a night guard. So you'd think she should be well. You'd think that. So we reviewed her medical and dental histories, took an intraoral dental scan, an iTero. We took bite wings, a few periapicals. I don't take FMXs anymore because we take a cone beam on every new patient, less radiation than an FMX. We did a full mouth perio exam and an intraoral exam. If you go by her risk factors, she's diabetic and she's overweight and has high blood pressure. So she's got the comorbidities of what can lead to periodontal disease. So she'd been seeing her previous dentist and periodontist with a history of multiple surgeries and active therapies. So this is all in the dental history. And for the last 3 years, all she's been getting are routine maintenance visits. This is us pulling her up in Pearl. And when we take the x-rays, they're immediately come up in Pearl. And as we're going to view in second opinion, AI in Pearl has identified calculus, incipient caries, progressive caries, and a periapical radiolucency. So when we dive deeper into Pearl and we just click on second opinion, this is what second opinion looks like. So these were her few periapicals and her bite wings on top of a CBCT. Each PA or bite wing may or may not have a color code. So each dot represents something. Green is for calculus. So what you can see here is that all 4 quadrants have noted subgingival calculus. Some have caries, and there's periapical pathology on our lower right treated lower right molar. But let's focus on one x-ray, and you'll see how I pull this all together. This is your typical x-ray that I've taken forever. Black and white and a lot of gray. As I convert it, I'm just going to walk you through this. The human eye has been shown to capture subgingival calculus about 50% of the time. AI, 80%. So now we can identify subgingival calculus in the green boxes. Now we can explain bone loss from the CEJ to the crest of the to her osseous crest. The white measurements are up to 2. It's really, I think, 2.5 millimeters. Yellow's up to 3, and I think orange is 3+. And this is important because once you've seen measurements beyond white, we have early bone loss, moderate bone loss, and then obviously moderate to severe bone loss. Again, I'll use color graphics like 2 parts to explain. But I think the most important part is when I have a patient and we can go in and take a look at existing x-rays and see the changes. So let's take a look. We go back 1 year to previous x-rays and compare. She's got a worsening bone loss here, so we have active periodontal disease. We have active periodontal disease here, where orange is worse than yellow. So on the right, you're seeing a worsening. Here on the left, you see it was in white. The measurement was 1 point something, and now we're over 2.5 in the yellow. So we have subgingival calculus, and we have now worsening measurements. Now let's integrate her probings. So we're showing her probings along with bleeding on probing. So we've got 2D imaging, bleeding on probing, and her imaging. In total, she had 24 bleeding points. 24. She had subgingival calculus identified by 2D AI, continued loss of bone showing between just 1 year loss of bone. And she's continuing to have A1C challenges via blood tests. So for the last few years, she's been receiving perio maintenances. How would you approach her now? And after years of periodontal care, is traditional active therapy enough? And I would tell you absolutely not. This isn't how we practice in our practice anymore. If she hasn't been successful and she's doing everything with oral hygiene that she's supposed to, there've got to be other issues going on. So I think we need more information for better treatment outcomes on these kind of patients. And they're in all of our practices. Again, 50% of perio, or I should say 50% of periodontitis is related to genetic or hereditary factors. So let's talk about additional testing. What we're talking about tonight is genetic testing. Saliva testing, as an example, would be oral genome, where they're testing bacteria, some enzymes, cytokines, and other things. Bacterial DNA testing, just testing for bugs. And I'm not saying just, it's specific for testing for bugs. And when you're looking at all these different tests, how are they going to fit into the dynamics of treating RINA? And this is what I call really specialty products. How you could be using Slate for power brushing, Live Fresh to lower your plaque, lower your gingival inflammation. This has all been proven by Live Fresh. What probiotics would be using? And I'm the biggest believer in Perio Protect. And for those of you who use Perio Protect, you're using it on patients who've had disease, who've had perio disease. Now imagine if you were using Perio Protect as a preventive measure that you've tested someone and they're in the high risk or intermediate high risk of developing perio. Perio Protect has been shown to be the best way to maintain our periodontal risk patients. And then how are you going to reevaluate this woman? Are you going to do bacterial or saliva testing to see, is she improving? Again, bleeding on probing is only indicative of 30% of a positive, or what we should say, future disease. So I think there have to be other ways. And as a dentist, you will put your own plans together, but AI genetics is a once in a lifetime test. So let me just kind of discuss this, I think, key point. Given her high risk with diabetes, high blood pressure, and her clinical history, the nature of the episodic disease that perio is, and her altered immune response, this is what we're dealing with. Would genetic testing assist you in this case? Absolutely. You want to know, is she high risk or not? And would it further motivate her? Absolutely. So if her test comes back genetically low risk, and you look at all of the ways you can approach her, this is how I kind of look at, this would be how I'd approach her with a low risk. Now, if she comes back high risk, do you refer to a specialist? That's up to you. Are you more determined to go beyond traditional scaling and planing, for example, with lasers or guided biofilm therapy? Does bacterial testing become mandatory as a baseline? Do you follow up bacterial testing to evaluate? Are you starting to use salivary testing? What kind of long-term preventative approaches are you going to do if she comes back high risk? And these are the ones I showed you. When you reevaluate her in 6 weeks, how are you going to decide whether she's going to go into perio maintenance, and how are you going to establish really what her supportive periodontal therapy is to be successful? I think she'll be more motivated. I really do. If she comes back with a positive AI genetic test, because she's going to know, in addition to diabetes, there are other things going on. So when we talk about implementing AI genetics, I really think it's, first off, who should we be testing? So when you have patients who come in with a medical history or a dental history that includes high risks of periodontal disease, your parents had it, your sister or brothers have it, or high risks of caries. Now, this can be as a family history, or this could be their own personal high-risk history of past periodontal disease, caries, diabetes, smoking, weight issues, stress, and dry mouth. I think all of these conditions would warrant genetically testing a patient. And then you go clinically. Who to test? I would think immediately, if I was beginning periodontal active therapies with higher risk patients. So if you know someone's got, we'll call it moderate to severe perio or early perio, I don't know why you wouldn't test these patients. If you were doing surgeries, I'd want to know, for both knowledge and risk profiles, of how are we going to protect this patient? Because how many perio surgeries have we seen, whether Lenap or traditional that goes south after a while. So how are we going to guide them pre-operatively and post-operatively? We're going to want to know the risk factors. Implants have a higher incidence of perimucositis and periimplantitis than we'd ever thought. Over half of all implants have perimucositis. And this is all attributable to risk factors and existing periodontal disease in our patients' mouths. And would you want to know the risk factors for large restorative casework that you're about to perform? And lastly, how to manage high-risk patients in a more customized approach. And I really think this really becomes paramount in how you want to start to categorize this. How would I explain it? I would tell a patient, I've looked at your medical and dental history. I'm looking at certain lifestyles, whether it's smoking, whatever you want to look at, vaping. You may be at higher risk for developing caries or gum disease. So you're going to look at their recent dental history, their past dental history, their medical history, dental history, all the environmental factors that we presented tonight. And then I would just say you may be at higher risk. And decades of research has shown that a patient's profile, genetic profile, may make them even more at risk. So I want to know, is genetics really a component here? And then I just say we have a really easy test, and I'm just going to take a swab. And if they're higher risk, we're going to have to develop more customized approaches to your care. Does this mean more visits to a dental office? It does, everybody. This is more income. I'm not saying this to sell more dentistry, but a high-risk patient is going to be in your office every 3 or 4 months. And really, you're going to have to follow them much closer than a low-risk patient. And then I'll just ask them, can I answer any questions? And I think it's an easy way to approach a patient if you're looking at the overall patient and not just using an Explorer and a 2D X-ray. Coding. These are the codes. An 0422 is a collection and preparation of a genetic sample. And it's a genetic sample, and it's being sent out for a laboratory analysis. So this does go out, as Stephen said, for a laboratory analysis. Another code, 0423, is the genetic test for susceptibility to disease/specimen analysis. So these are 2 codes that you can use. Does it mean insurance is going to pay? No. AI Genetics will be working with insurance companies, but insurance companies have got to figure out, if they're paying for blood tests, why wouldn't they ultimately want to think about more prevention and do genetic testing? And lastly, compliance. I think we have not created the need for a patient. And when we don't create this need, it doesn't drive them to want their care or follow our recommendations. I think this will really, really create a need. And once the patient really sees they really need to listen to what we're talking about, we'll be far more successful. To close, I think AI Genetics may create that understanding of need and then turn patients into understanding why they should want their care, want their prevention, why they should do more. And this is why I think tonight it's part of a turning point in how we can be practicing dentistry in a far more predictive manner. I'll say thanks for joining us. The first question that was typed in was, how much should we charge for the test? So I'm going to have Suzanne go over the cost of the test, of really what it is in Canada and what is in the US. What would I charge? The test itself in the US, Suzanne, just we'll get to it, it's roughly $100. That's the cost to the office. Is that right?
Yeah, so it's $110 US dollars and
Right.
150 Canadian dollars.
And we're going to show this. But
Yes.
what would I charge? I will tell you that insurances right now are paying up to $180 for this test. So I think that's very reasonable to charge a patient. But again, It really depends on each office to answer that question. If it's costing you $110 and probably, I would say 10 minutes of time conversing with the patient and doing the swab, then whether you want to feel it's part of your overall therapy and just charge the cost of the test, that again is up to you. But I will say insurance companies that are paying for this do pay up to $180. So that will answer that question, I hope.